Yeah, again, it's a pleasure. Okay, it's a pleasure to open this second webinar in this series, based on popular demand. Actually, it was a huge response for our webinar last time. Many questions, a lot of participants, and great interest. So for that, I'm thankful to Chris Ogilvie and Phil Towski from Harvard, and we are here back to answer more questions. But before we do that, on behalf of myself and Mako Sato, section chair of the vascular section of EANS, and then Nikolai Velinov, who is a hybrid neurosurgeon in Sofia and is the chair of the hands-on committee of the EANS. So we're here to moderate, but I think we give the floor to Chris to start with a short introduction. Then we will receive your questions. Please use the Q&A button for the listeners and not the chat box. We will not take questions from the chat, only the Q&A. And preferably more general questions rather than specific, questions like, I work in this country, can I come? Can I do fellowships? Regarding specific visas or whatever, are not really suitable for the general public. So we will focus on the more general questions. Last time we had 4 main groups of questions. One is regarding practicalities of doing a fellowship in the US. The second is formal requirements. The third is organization of a vascular service in the future. The need for endovascular, hybrid, or open. Do we need one of each, or how this should be done? And the last, treatment options, are more specific cases again, surgery versus endovascular. The purpose of this is more to address the 3 former ones, namely the practicalities, the formal requirements, and the organization of a vascular service. So without further ado, Chris, the floor is yours.
Thank you, and thank you for having us. And Phil, as I told you, is actually doing sort of an urgent procedure. Can you see my screen?
We do.
Yeah.
Thank you.
Okay, I thought I'd just open quickly because I got a number of emails about education after the last webinar. So I thought I'd just talk about that for about 8 or 9 minutes. And no disclosures relative to this talk, but just a couple of patients to illustrate how fast this has changed. And this gets to one of the topics you covered, which is, do we clip, do we coil, what do we do? Here's a 56-year-old cavernous intracranial aneurysm that was symptomatic. She had cranial neuropathy, failed at balloon test occlusion with poor collateral circulation. So we decided to do a saphenous vein bypass with carotid occlusion. She also had a small MCA aneurysm. And at this point in my career, we were doing the carotid occlusions at the time of the bypass. We didn't do it endovascularly, we would just do it open. But you can see, here's her imaging. Here's her MCA. She has a small aneurysm. And you can see the cavernous aneurysm is pretty sizable. And on the lower panel, you see the CTA of the cavernous aneurysm. She was only 56, good age. And here's her isolated hemisphere. So we went ahead and this was more the CTA. And you can see we went ahead and did the bypass. You can see the bypass coming in here. This is the MCA aneurysm clipped. I won't drag you through the video, but this shows the saphenous vein. We plug it into the carotid artery and do a bypass. And then we'd occlude with a clip in the carotid in the neck, and the aneurysms would go away. And these were very effective. Fast forward 5 or 6 years. This was when Pipeline was first developed, but I used to do one of these a month. And now here's a classic situation you guys have all seen many of. Here's a 63-year-old who had a cranial neuropathy in this aneurysm. And, 6 months after a Pipeline, this is her artery. That aneurysm is completely gone. I will mention she did have a small ACOM aneurysm here filling from the right. And we went ahead and clipped that in a separate setting. But this is, become part and parcel of our work now. All these patients who used to get bypasses and occlusions or paraclinoid aneurysm surgery, I used to do 1 or 2 paraclinoid aneurysm clinoidectomies a week, are now all treated with flow diversion. And so that's just a sort of to start the discussion. And then people ask me about neurovascular education. So we do this at every level. So undergraduates approach us and we get them involved shadowing us. We get them involved in our research projects appropriate for their level of training. In medical school, they approach us for individual mentoring and research. And then I've started giving a neurovascular course for students and residents, I'll show you, which has become incredibly popular in New England and northeastern United States. And then the residents, we have 2 rotations I told you guys about last time, total immersion, 4 months each at year 3 and year 5. And they leave the residency really ready, able to do basic angiography and some simple endovascular work, as well as some of the open work. And then the 2-year fellowship, I'll just show you some numbers from our fellow who just finished. We do postgraduate education. We have an annual course for physicians in stroke and hemorrhage. And then nationally, Dr. Towski and myself, Dr. Granstein, our other partner, lecture and speak at national and international courses. So undergraduate education, as I mentioned, we foster their involvement. And in medical school, they do rotations. And I started a course. And what happened a couple years ago, as the students came on the service, they really didn't have good neurovascular education. So I started a course for the 1st and 2nd year students. And it just started with the interest group here at Harvard. And just by word of mouth through the neurosurgical interest groups, we had buy-in from 8 institutions. The first year I gave this course, I thought 20 people would show up. It's a hands-on course. So I have the vendors come and they can do angiograms on the simulators. They can do, coilings of aneurysms. And the first year we had 75 students. Last year we had 130 students. And we have lectures, which are given by our fellows, our other staff members, myself. We have didactics, but then we break off and have hands-on. And you can see here they are working under the microscope. These are 1st and 2nd year students, so they haven't even seen patients yet. But we have them do micro clipping of fake aneurysms. We have them do micro suturing with 8 and 9/0 suture, and they love it. And here's all the stations around the room. You can see they're spread out and each doing different procedures. They break up into groups. They can do angiography. And as you all know, the simulators for these are getting better and better, more and more accurate to what real angiography is like. And here, in fact, they're coiling an aneurysm right on the angiogram. So we continue that. And then in residency, I mentioned last time our rotations, but I'll just show you our recent graduate. This is after a 2-year combined endovascular and surgical residency fellowship. These are people who are done with their neurosurgical training, and they do both endovascular and surgical work at the same time with us. So they usually spend a couple of days a week in the endo suite, a couple of days a week in the OR, 1 day in clinic. And our fellow who just finished last week, he published while in his fellowship, 29 manuscripts for his academic work. He has 21 manuscripts pending. He came to us with 7 papers that he had written. He's given 16 podium presentations, written a couple of book chapters, and he did over 1,200 procedures, cases, which you see here, the things he did. This included his endovascular work. You can see there's about 500 angiograms, 500 or 600 angios, and then the work with the aneurysms, flow diversion. He did 122 strokes, mechanical thrombectomy, aneurysm clipping, aneurysm coiling, middle meningeal artery embolization, very common at our institution, AVM embolization. You can look down the list at the different procedures, bypasses, indirect bypasses, and then all types of spinal angiography, spinal work. But you can see they have a pretty rich experience, both in terms of depth and breadth of what they do. So I'll stop sharing there. We do beyond the training, we do this course every year for general physicians too. We usually get about 130 people who show up to get educated on neurovascular disease, who are general physicians and emergency room physicians. So that helps with our referral base. It helps educate the general physicians so they know what we're looking for to see. But you can see once you do hybrid work, and Nikolai will attest to this, there's really no place you can't go. And now we're doing venous sinus stenting. There's a lot of work going on that we weren't doing 5 years ago. And I'd be happy to invite Nikolai to make a comment on that. But we can break in, Torsten, to your comments at this point or questions if you'd like. I just thought I'd put that out there
Yeah.
to show where we've been.
Wonderful, Chris. Thank you. Now, again, like I said last time, these are very, very impressive numbers, and I like the way you have, well, target each group, starting from students, and I'm sure Marco will also comment / have some questions regarding that. But following up on that, Nikolai, could you comment on how, let's say, the endovascular practice in your surgical practice has enriched and influenced your practice?
Absolutely. I believe Chris is absolutely right. When we were doing mostly open procedures, of course, we had a large number of aneurysms and AVMs, but doing endovascular actually allows you to combine modalities. And in some patients, you can combine open modalities with endovascular, which is actually much safer for the patient rather than doing either approach separately. And I think that this is something I always say, that if you do the full spectrum of endovascular, and as I see you are doing also carotids and stroke. Actually, once you start doing stroke, you get to have all these patients with total occlusion of one of the ICAs, and then many of these patients, yet patients, are actually eligible for bypass or for EDAs. On the other hand, you have some patients for endarterectomy. So I would say that going into endovascular actually increased a large number of patients which need a surgical procedure, and you increase the number of procedures you're doing and the variety of vascular procedures you're doing, and this has changed absolutely my practice in terms of also endarterectomy and carotid stenting, and I believe that this is one of the main points. Is even whether you're doing open or endovascular, both of them will give you a perspective, and then endovascular really helps you to improve and increase the number of modalities in patients that you're treating. So this is how it also changed my practice very largely, and it still is evolving, I would guess, because we started doing stroke recently, like several years ago, and I would say that that's still to come with many of these patients.
So in your hands, let's say you have enough vascular to Nikolai to live off purely vascular now. I mean, you don't need to fill your lists with lumbar discs or chronic subdurals, right?
Chronic subdurals, we embolize these, as Chris elegantly.
Yeah, okay, but trepanations and
but this is also something in Europe. It's less, let's say, popular, but still, I would say now with the evidence-based data, more and more a very hot topic, and I think that this is still to come. But I think that if you are doing the full spectrum of endovascular, I have reduced. I'm not doing almost any spine, and I do a relatively, let's say, fair share of cranial procedures in terms of tumors, and but this is all part of also, if you're doing bypass, you cannot just stop doing cranial surgery. So I think that you would still have a large number of cranial procedures that you're doing. But the fact of the matter is that if you're doing a full spectrum of endovascular, if you're doing stroke, practically there is no way you can do general neurosurgery. You cannot just do everything. It's not possible due to the large cases of vascular procedures you will get. Especially there is a large demand for stroke for endovascular specialists, and there actually we need more endovascular than open surgeons, open vascular surgeons. And in my scenario, and also I think all the hybrids, we were first trained in open vascular neurosurgery and now doing endovascular. It's a totally different perspective. But if you want to be a hybrid now, at least in Europe, it's a bit different perspective than the US. I think that more from a training perspective. United States I think gives more opportunities in terms of the larger caseload of open vascular procedures in comparison with Europe. And this is mostly related to the population in the countries. For example, in Bulgaria is 6.5 million, and as compared to large states and countries where you have a 60 or 80 million population, there probably the number of open vascularly treated patients is higher.
Yeah.
Marco.
May I say a comment? Yeah,
Yes, please.
of course, I totally agree that the neurosurgeon has to go in the endovascular field. And I think also that at least what I see here in Italy is that we have a large number of endovascular procedure, and the surgical open procedure are going less and less. Of course, you have to centralize because as a well-known topic, the complex case remain open, and so you have to centralize. But I think also that one of the risks is that if the new generation, the residents are not involved in the endovascular, at the end, they are not interested and they lose the mindset of thinking on vascular. So they will delegate everything to the endovascular, to the neuroradiologist, and at the end, we will have no one, this is a well-known problem, no one that do open vascular, but I see that the young generation it's hard to attract them in the vascular surgery. Otherwise, we work in a reference hospital, but on the other hospital, the smaller one where you don't have reference that comes from all Italy, at least here with complex cases, it's very hard to see that the young generation moves toward vascular, because spine is much easier, less stressful, maybe you get more money, and why to spend the night operating an aneurysm when you can send it to the radiologist? But the problem is, if you don't enter in this field, you will lose this mindset and you will do not understand what is good for surgery and what is good for endovascular. And at the end I think it's a very dangerous. Another may I say another thing? I see that at least in Italy, but also in Europe, we have to fight against the radiologists because they do not want to leave that field. But I think that we have to fight also against some neurosurgeon, because you can feel that there are many neurosurgeons that say, if you do endovascular, you will never be a good open surgeon. You cannot be both. But as a neurosurgeon, we can do gamma knife, we can do spine, we can do transnasal surgery, which are completely different way of working. And so as a neurosurgeon, we can do both, I think. I am too old to start, and I don't need, because I have a very good endovascular team I work with. They are very good, and there is no need. But I am pushing my young resident to spend time and to enter in the endovascular field, because I think that this is the future for vascular surgery.
Thank you, Marco. Chris, do you have any advice to?
Yes, a couple of things. First of all, Marco is very wise. And, you know, when I was mid-career, I was telling people you have to do endovascular, but I wasn't providing the role model. Now they see someone who does endo one day or one afternoon and surgery the next morning and clips an aneurysm and then coils one. And there's a couple, so you're very wise. And all it takes is one. Once you get that role model, once you have one surgeon doing it, who's a good surgeon, but also good at endovascular. And I'll tell you, I know there was this mindset, oh, it's easier, they're not as good a surgeon. It is technically can be exceedingly challenging. And it's how you think about things. Now, I will talk about stroke just for 1 second, because I think that's the thin edge of the wedge, as we say. It's a matter of person power. And there's two things about it. One, no pun intended, well, kind of pun intended, there's a penumbra effect. When you treat stroke, you see people who are coming in with seizures who have a meningioma, stroke mimics. So I am actually giving cases and patients to my colleagues who do general neurosurgery who don't have strokes, but they come in initially as stroke. So that's one issue. Two is, it's estimated that about a third of stroke patients might benefit from thrombectomy. And in the United States, we're at about, depending on where you are in the United States, we're at about 12%, 14%, you know, different places are treating a different percentage of patients. Still, not all of them are getting it that need it. If you look in England, where the radiologists are really blocking the surgeons from learning endovascular, 1% of patients are getting thrombectomy. And in my mind, that's just not right, because you see these patients, and we are presented with patients all the time now, 80 years old, 82 years old, 86 years old. They walk out of the hospital 2 days later after a thrombectomy. So stroke is going to be the area where it's pushed because, as Nikolai mentioned, it's numbers. There's so many of these patients that neurologists, radiologists, neurosurgeons can't do it on your own. So there's going to have to be some type of mixture of teams. And the other thing that comes up in the United States is we have a service and we offer stroke care. You can't have 4 neurosurgeons who do both endo and open surgery because there's not enough open procedures. But you can have teams form where there might be a neurologist. We have a neurologist who works with us who's in surgery, and 2 surgeons. And we're thinking of, and we're working on recruiting another neurologist or radiologist as part of our team. So some of them do just endovascular. The neurologists sometimes do endovascular work and then also work in the ICU. And then the surgeons can do endovascular work and also work in the operating room the rest of their time. So it's a mixed practice on everyone's part. But it is complex. However, I think Marco is wise in his comments and Nikolai in his example. Remember what happened in cardiac, or look what happened in cardiac surgery. You know, the arrogance was, we'll never need to know how to do that, those catheter things. Well, now, at least in the United States, almost all the cardiac programs, open cardiac surgery programs, which they had a hard time filling for a while, have some element of learning endovascular techniques for aortic valve replacements and other intravascular procedures. So I think the neurosurgery, at least in the States, has been wise and, you know, not arrogant, and said, no, we need to embrace this field and make it part of our armamentarium, make it part of our regular service. And we're trying to do that more and more. It is a different skill set and it is a different mindset sometimes, but once you integrate it into your thinking, and Nikolai knows this, it just becomes part and parcel of the way you think. The worst situation you want to be in is when you're clipping something that should be coiled, or you're coiling something that should be clipped. And then you feel like, oh my gosh, that's not where I want to be.
Yeah, thank you, Chris. What I really like is that you bring in different specialties. I think one way to move forward is to break down the silos. I've always said, you know, I don't want to take over anything. I think neurosurgeons in this field has something to offer to move the field forward, because we bring to the table other skill sets than the other specialties, including neurology and neuroradiology. So I think together we make a better buffet than keeping this silo and excluding people.
Hello.
But what about an advice for let's say getting the young people interested? You mentioned some examples, and I know Marco is trying to even have medical students sort of rotate a bit, or at least be exposed, and then have residents do some mandatory service. That was for you, Chris. But
I think it has of course, I'm trying because I'm not in a university hospital, but I have several residents that comes here, and some of them, is not all of them, but you have to see which are more interested in that field. The one that came here for vascular, I send them also in the neuroradiology just to do some practice during their residency. And so maybe they decide that it will be nice and they are interested, but it's something I think that they have to be exposed to that during their residency.
do you have any advice for Europe, Chris?
Well, we've adopted a plan where we have 2 they're part of the residency, the rotation. One is a more junior resident. And the reason we do it then for 4 months, and they learn basic catheter skills, and we make sure our fellows are pretty mature. They're done with their residency. So we often have them take our place at the table, teaching the younger residents how to learn how to do how to get femoral access, how to do an angiogram, how to handle a catheter. and it's real hands-on. If they're just standing there watching, as you all know, with surgery, it's not the same. And with careful guidance, they can be taught how to do this. Now, we have it do it early on because sometimes they say, hey, you know, I really am starting to like this. And then they can do an enfolded fellowship or plan on a fellowship after residency. It gives them time. If all of a sudden they find out as a 6-year resident they like it, that sometimes the timing doesn't work out. But I think you're wise, Marco, to have people get the exposure, because that's how they start to think about the disease as a disease, not just as a technique.
Yeah.
If I can, sorry, I had a case
Yeah.
that I had to finish up, but yeah, thanks for doing that again. I just wanted to answer. There were two open questions, and I pressed the wrong button. I apologize for that. One question was, you know, do we think that angiography should be part of neurosurgery residency education? And I think both Chris and I and many other vascular leaders in the US feel very strongly that this is part of neurosurgery and this should be trained as part of neurosurgery. And as we alluded to the last time, you know, we all our residents rotate with us and they become good at angiography and thrombectomy. And, you know, if you look at the need for stroke thrombectomy in the US, in Italy, in Eastern Europe, right? We undertreat a lot of stroke patients. And we think part of the solution is treating stroke thrombectomy like a laminectomy and epidural hematoma, that every neurosurgeon can do that, irrespective of your subspecialty interests or clinical practice. And the other question that is from Simone, I think that is, of course, an important question. Many young neurosurgeons feel that endovascular is a diminishment. And I completely understand where that's coming from, but I can tell you, and Chris Ogilvie is one of the experienced vascular neurosurgeons, and you can ask him directly, you know, do you feel a flow diverter is less of a case than a bypass or a clipping? And I can already tell you the answer he's going to give you, that it's just as fun, it's just as interesting, it's just as technically demanding. Endovascular has one big advantage, that when you do an elective endovascular case, the patient goes home tomorrow, you know, without a scar and without any issues. You know, it's hard to beat that feeling that you get. But we need to get away from these kind of thinkings and just focus on what's best for the patient. And there's no question in my mind that we can really offer as neurosurgeons, because we have all the tools in the toolbox, we can really offer a lot for our patients. But I would love to hear other people's opinion on this.
Yeah, do you want to comment, Chris, or?
No, I defer to others. Maybe Nikolai. I think Nikolai has a very similar, has evolved on his own, a very similar kind of practice and experience. And once you get into this, it's a very rich practice. And I love vessel, I love vascular, I love vessel. So it's all I do. It's all I've done for a while. But it and Dr. Towski does some tumor work on request, but it really is where we live, and also having good partners. Of course, you can discuss things with. These are tough cases. When you have complications, you have to have partners who back you up. And this is, Torsten, you mentioned the silo concept. We've taken that out of it. In the United States, it's about, some of it is about billing and money, and we've tried to take that out of it. We're all in the same department, we're all in the same division. So it's less of that. I was at another hospital at MGH for a while where it was siloed, and it got contentious because it was about money. Now, in other countries, that is not what it's about. It's just that maybe the radiologists don't want the neurosurgeons to learn. Someone put in the chat or the questions, you know, people leave the UK and they learn endovascular, then there's no place for them to come back to because they're not allowed. And we really, as you said, that barrier should really fall, because we're going to need the person, they're going to need the person power for strokes and other disease. The more you look, the more you find. And Nikolai, as you said, you know, chronic subdurals at our institution, if you start looking at the propensity match data, It's beneficial on its own. It's beneficial instead of surgery. It's beneficial in addition to surgery. So it's become very collaborative with the people who do the open surgical procedures.
Thank you, Chris. Do you want to comment there, Nikolai? Or
Yeah, I absolutely agree, Chris. I wanted to comment on the question of Simone because this has been the everlasting question, whether a vascular surgeon is killing his career by going into endovascular. And from my personal perspective, we should avoid thinking about vascular surgery, scalpel, or a catheter. A procedure can be open surgical or endovascular, but they are both microvascular. And I can assure you there are many cases where you would simply find it much easier to do a 10-0 stitch than coil a 3 millimeter aneurysm. And when you're coiling a 3 millimeter aneurysm by itself, it's a microvascular procedure that is, in my opinion, in my hands, very close. If you're a microvascular surgeon, you would find the resemblance in the skills that you would need doing both. Of course, you're using different instruments, but we're living in the era of robotics. As spinal surgery has changed, endovascular is just another tool. You should be able to use it and use it for the good of the patient and for doing the best treatment modality of your patient.
I would also add a facet that we haven't really discussed, at least in depth, and that is the understanding of the pathology, the flow, and how intellectually stimulating that can be. It's more than just the technical aspect. Same with with surgery, microsurgery. You have the elegance of recreating the anatomy, which is super appealing, and the highly turbocharged your motor cortex. But the endovascular is also intellectually stimulating, because there are diseases we don't understand, and you see flow in a completely more dynamic way than we do with, let's say, static 3D CT that we use for clipping.
In regard to that, I might comment that we have increased largely the number of simple diagnostic angiographies in most of the tumors that we're doing, and sometimes you get a lot of information from an angiography regarding the arterial blood supply of the tumor. And we have really started to do angiography, diagnostic angiography, and this is something that was very elegantly said by Phil and by Chris. I believe that diagnostic angiography should be part of the training program of all neurosurgeons, because it gives you the concepts of flow. The 3D CTA is a picture you see, a moment picture with contrast, and it's totally different thing. And especially in AVMs, to understand the flow, you need to understand the angiography. And if you don't doing the angiography yourself, if you're not doing selective angiography, it will be very difficult to read this only in the books and not realize it. So I believe this changes your perspective, in my opinion, and should be performed whether you have the full spectrum of endovascular or you reach a certain level. I think angiography should be performed by most neurosurgeons in general. It's
I totally agree. And remember, 15, 20 years ago, before we had neurointerventionalists, general neuroradiologists do angiography. I was at an institution where there was 7 or 8 people doing it. They'd do 10 or 15 a year, and their complication rate was high. Now, the complication rate of our diagnostic angiography it's quoted at about 0.5%, and we run about half of that. Doesn't mean you do it in everyone. It doesn't mean you're cavalier about it, and we're very selective. But it's still part and parcel of a test we do now, and it's safe. And as you say, Nikolai, we get a ton of information. But to your comment, Torstein, about the thinking of these diseases, Dr. Towski and I, we sometimes ask practitioners to come in the control room and watch as we're doing a procedure to help comment as things change. Dural AVMs, case in point, as surgeons, we do dural AVMs, we work on them, we understand them much better than 15 years ago. And as we're working on them, we get to a point sometimes, hey, wait, let's stop. Let's do the rest of this surgically. And we do. And it's so much better for the patient, instead of trying to push an endovascular tech too far or taking someone to the OR who would be well better served with endovascular. But dural AVMs is one of those examples where you really need often both and good input from both. But you have a facility with both so that you're comfortable when to stop, when to go, kind of thing.
we have tons of questions coming in. So if I may, could we just, Rafael Guzman asked, how to get access to machines blocked by radiology. Simone answered, we have a hybrid room. It might be the answer. This might be more European than American thing. I'm not sure, but Phil perhaps has a thorough understanding of both healthcare systems.
Yeah, the blockage of radiology is not really clear in the European system, right? What does it relate to? Does it relate? They don't own the machines because the hospital owns the machine. The hospital buys the machines, and so that block from radiology has never been 100% clear to me. What does it really relate to? Because they don't own it. They don't certify it. I think one way to go around it is really if neurosurgery has a formal pathway to endovascular, right? If we say, these people are trained, these people are certified, if you have your own board, if you have your own training curriculum, it's very hard to keep people out. People like Chris, who's coiled 1,000 aneurysms, who's going to tell him, or maybe more, sorry, Chris, but who's going to tell him, you can't do that on the basis of what? And I think, so, when I came to the University of Utah, there were 3 radiologists and I joined them. And we just pushed the patient safety aspect. We said, it's safer if neurosurgery does it because we take care of all our complications. We are the only ones who can make a decision of open versus endovascular. And the dean of the hospital, who was actually a radiologist, sided with neurosurgery and said, yes, this is a neurosurgical field. And now we have 4 endovascular neurosurgeons at the University of Utah who run this business. And it's much quieter, it's much better. I think it's better patient care, it's safer. But I think you need a curriculum, and I think you need a way to certify people.
Point. Then we have, there are some. If we could move towards the, let's say, the fellowship aspects, the formal requirements, the practical requirements, etc. You probably saw last time also there were quite a few, which USMLEs, how do you apply, how do you become a good candidate, interviews, etc. Could you comment or take us through some of these steps, Chris or Phil?
Yeah, I can start, and then maybe Chris can. So the USMLE is really the key. It opens a lot of doors. I know it's difficult if you're in training and you work as a resident to take the USMLE. And the USMLE is a very American exam. It's hard when you come from European medical schools, but anyone can take it nowadays. It's really become, you have these question banks online, USMLE World, and you just do all the questions. And I think that's the way to do it. Don't open any books, just do the questions and do them over and over and over again. And in those Q banks, they give you actually the explanation for each question. So you learn as you do answer the questions. And then, of course, be academically active. That's how we evaluate our fellows. We don't look at the score of the USMLE, as long as you pass the USMLE, you're fine. But we want to see that you're engaged and interested and that you do research on vascular topics or any topic, that you have a drive, that you have an interest. In general, I think European future fellows are in a good position because people like Chris and I, we like to train people who go back and have a big impact in their home country or in their academic system. That is very attractive to us. You can always come as an observer if you're interested in Buffalo, write them and say, I want to come for 2 weeks, can I come have a look? And so they know you, and so when you apply, it's easier. There's many different ways, but for me, it all starts with the USMLE and being academically engaged. I don't know if Chris, what would you like to
No,
know?
I agree. And in the United States, it's the requirement is 1 year of endovascular training, of dedicated endovascular training. Our fellowship is 2 years because it's endovascular and surgical. So we made it 2 years for that reason. But for most, it's one. I will tell you that the plan is for the year 2027 to have a match for the endovascular programs. And these are programs that the people applying are neurosurgeons, radiologists, and neurologists, and all three subspecialties can apply. In our particular situation, we rely on our fellows to be in the OR as well as in the endo suite. So to date, we've trained surgeons, neurosurgeons, but we have had radiologists and neurologists rotate on our service. We also been approved by the Congress of Neurological Surgery. They had a grant and they asked us to apply and we got it. So starting 2025, we do have 3-month rotations. They're observerships. They're not hands-in, hands-on for European individuals, mostly European or international individuals to come and spend 3 months on our service. And the Congress helps subsidize with funding. So that's another avenue. But all of this, I started doing endo after 20 years of just open work, and you really have to embrace it. You've got to be immersed and embraced. And if you do it as sort of a part-time thing, or this is something I'm going to do to say I do it, that has never really panned out. I think people who really embrace it and make it part and parcel of what they do day to day, it becomes successful, and then the practice builds from there.
In terms of how many programs are there in the US, and how many realistically places are open to non-US trainees?
Phil, do you know the number at present? It's a shifty number, and what people call a fellowship is different in different areas. You really want to seek out higher volume places, and I don't know the actual number. Phil, do you have any info on that?
No, but there's probably somewhere between 30 really good fellowships that you can apply to that will be open to international medical graduates. And there's probably another 20 to 30 that are less high in volume, but that you could still get, a good education. One of the biggest fellowships in the country, Buffalo, they take, some years to have 6 fellows, and they're all well trained, and they're actually very open to international medical graduates. Just to give you an idea, I mean, 6 fellows in total is a big number, but they're all well trained. They all do very well. These things can change so quickly. All you need is a few advocates in Europe. I know you already have some in Holland with Joost de Vries and so on, but if you have a few more, if you have a handful of really cracking endovascular neurosurgeons, Simone and so on, then you can change that very quickly. In 5 years, this may be a very different discussion.
Yeah, we had one fellow we trained from Saudi Arabia. He trained in Canada in his residency, came to us for his fellowship and went back to Saudi. He set up an endovascular open practice, and he's changing the culture, really. And now he has fellows. So that definitely has an influence. But as Phil says, you can get the experience a number of different ways, and it's not totally, it's not as rigid at the moment.
Well, I think at the organizational level, not at the EANS level, but the hospitals would, let's say, a partnership or joint program between, let's say, Marcos Hospital and MGH, at a more structural level. Could that be one way forward? I mean, that would bind the hospital in many ways, right? As Phil said, it's the hospital owns the machines. So could we, would that be a viable or possible solution to sort of bind the hospital to commit in a way by taking a step like that?
It's an interesting idea. I never thought about that, but yeah, it's a very interesting idea. We are very interested in general in these hospital associations and collaborations. The problem is once you have the hospital leadership involved, it becomes very legalistic and so on. But
Yeah.
in general, I think it's a very good idea.
I will tell you, having trained neurologists, neurosurgeons, and radiologists, it is a lot easier to train neurosurgeons. Their learning curve is very quick. They pick this up. They already know about patient care. The radiologists sometimes need to spend extra time in patient care on the ICU, learning just basic care. Neurologists have a little more knowledge about patient care, but aren't not as a rule, but aren't often as facile with their hands. And this really, as Nikolai said, you know, microcatheterization, microskill, the people who are good at microsurgery tend to be really good at endovascular and have a nice touch. They have a good feel for the catheter. And when you're doing the microcatheter work, it takes a very, I'm with you, Nikolai, coiling a 3mm aneurysm. I sometimes wake up at 4:30 in the morning, way more nervous than a 10mm aneurysm, I can tell you, because of the risks are different, you know?
You want to comment, Nikolai?
Yeah, I absolutely agree on everything said, and I can comment on. I see many questions regarding how to start doing this. So some people are being blocked. I think that even in Europe now we're getting at a stage that where radiologists, neuroradiologists, are joining neurosurgeons together. And I have to be honest that we started working, and we're still working together in the cath lab with cardiologists, but I think that on a general level, the neuroradiologists realize that they cannot do this alone. And why is that? Because you need a stroke center in, let's say, every major city, and it's just not possible to have the number of people. And I think one of the ways would be to just say, hey, I'm trained, I can do this, and you need help, and just discuss it. Rather, you don't need to fight with them. I think that more now is a problem, at least in Bulgaria, that cardiologists want to do stroke because of the neurosurgeons or radiologists cannot solve a simple question between them. So to be honest, I see, and at least in Bulgaria, we have a very, very prominent relationship now with radiologists in terms of trying to work together, knowing that this is a very large field, and neurosurgeons can help. And of course, in every center, the neurosurgeon is needed to take care of the complications. So I think it's one of the things that you have to have neuro in your specialty, whether neurologist, whether neuroradiologist, whether neurosurgeon, to treat this and to get this. And I absolutely share what Chris told me. I spent some time with René Chapeau in Essen, in Alfred Krupp, and that is what he said. I'm stealing residents from the neurosurgical department because they get trained for 6 months. The radiologists, they don't work so much with their hands, and the training program for them is much longer as compared to neurosurgeons. So that is the fact of the matter, is everywhere it's true, and this is very easily explained. Neurosurgeons just have more experience with their practical work from day one, and that is why I will say it again. For me, it's just another tool.
May I say
Yes, please, Marco.
no,
Yes.
But I know that there are some very some resistance, some difficult. But I say it again. I think that the work that you, Torsten, are doing, and we all are trying to follow, is we have to convince to distribute the idea in neurosurgery that endovascular is something that has to do with neurosurgery. Once all the neurosurgeon has entered in this idea, the way we will find the way. Now it's not yet in Europe. An idea is something that pertains to neurosurgery. And so I think the most important thing we have to do is to spread the idea is something that we have to enter. And so little by little, the young generation will find a way. The radiologists need us for the stroke. And so I think it just, you have to start, and we have to start a wave in that, because until a couple of years ago, it was something that was not our job, at least in Europe. But
Yeah, now and if I may add and answer some, or at least comment on some of the Q&As that we have seen, it's been a suggestion. Why don't we liaise with the cardiology or the inverse of that? You know, if the cardiologists are knocking on the door, on the stroke door, you know, and they want to go north. I've tried to convince, and will continue to do so, that our new radiology partners that we have more in common than or they have much more in common with us than cardiology, for instance. The understanding of the brain, the love for the neurosciences, etc. So if there is let's say a external force, huge, very powerful force knocking on the door, they should probably you know, better liaise with us than open that gate. That's my opinion.
In the States, cardiology was interested early on in endovascular neurointerventional, and I think they got into issues with lawsuits. This wasn't their specialty, and they had problems. They didn't really know the anatomy, and that I think the curve has gone down. There are parts of the United States, a country, where general interventional radiologists do collaborate with the neuro folks. There just aren't, again, it's person power, and they do stroke call. And some of them are quite excellent at it. They get quite good at it. Now there, it's a little more similar in terms of the vessels they're working in and that type of thing. And they take instruction from neuro. And cardiologists have so many other things to do that it falls down on their list. But there are places where general you know, interventional radiologists have picked up neuro and help cover and do procedures.
Yeah, and also with respect to radiology, of course, there new radiology self-images that there are. I mean, they come through the ranks of radiology, right? But again, I try to convince them that the only commonality they have with other radiological specialty is the same machine. You know, they have more in common with us, with the CNS and the brain and the neurosciences than they happen to share the same MRI machine, use the same tool. I mean, you can use a hammer in different ways. Orthopedic surgeon and a carpenter, or both use a hammer, but of course, orthopedic surgeon will have more in common with a neurosurgeon than so there are some, let's say, some conceptual discussions that we need to have.
May I ask you something to Chris? How is in the States the idea of having a master in radiology, in neuroradiology? I mean, we as a neurosurgeon, we trained on open vascular surgery for at least 10 years, and before reaching an aneurysm, you have your chief or your boss that for many years will say you, what the hell are you doing? You have to do this, and he's training you for many years. The impression I had in radiology now here, at least in Italy, is to do thrombectomy is very fast. You have a very rapid learning curve, and it's very fast. And I see many neuroradiologists that starting to do, young neuroradiologists that are starting to do thrombectomy, then not having a chief, a master that say, what the hell are you doing? Because of the same kind of gray, they shift to an aneurysm and then maybe so on an AVM without having being trained on that. Is that something happening also in the States, or?
It's a good point. It's something Dr. Towski and I talk about a lot. It's hard to know, you know, which comes first, the chicken or the egg. All that training, the training curves for the skull base and the open surgical procedures are a lot steeper and longer than endovascular. That's the bottom line. And then what's happening in the United States is a lot of the chair people, men and women, are recruiting younger individuals out of their fellowship. They don't have to pay them as much, and they can get their neurovascular program off the ground. They're more willing to take more arduous stroke call. So there's lots of politics that go into this whole thing. But what you say is true, that the avenue, once they learn the avenue, you can, now with the current catheters and devices we have, we're doing these thrombectomies in 7 to 9 minutes from groin to vessel open. And but once people learn that avenue, it's what you get to and what you do when you get there. Your point is extremely well taken. That is, the microcatheterization, they're not the exact same skill set. And that's where Dr. Towski and I, our fellows who are 3 months from finishing are doing very different parts of the procedure than the ones that are 6 months into it. And it's a graduated thing, just like surgery. And they need guidance and learning at different stages. And there's different parts of the procedure that they can master at different parts of their training. It's interesting, in endovascular, it's a little easier to hand over a case back and forth. Hey, you've gotten to a certain point. Let me take that next little bit. Okay, now you can take back over a little bit. It's harder to do that surgery. You get out of the chair, you get out from under the scope, and the next guy gets in. It's a little bigger of a deal, but we still do it. But it's something that Phil and I talk about a lot in terms of graduated. What you're alluding to is graduated responsibility for the micro work. But it happens in a very parallel fashion in endo as it does in open, I think.
And I think you're also alluding a little bit to just the clinical judgment, if I understand your question correctly. And I know you do a lot of, AVM surgery, and I completely understand where you're coming from. Chris and I, we used to do a lot of AVM embolizations and in surgery, and we're sort of getting away a little bit from it because it's a lot of discussions that go into these cases, and sometimes we end up saying surgery is actually a lot safer in these situations than doing embolization and surgery. Sometimes we feel different about radiosurgery. We do think sometimes knocking it down and then do radiosurgery is a much more reasonable path of treatment for these patients.
Yeah.
But it's a very nuanced way of treating a lot of the vascular pathology. And it's harder to do it with a neuroradiologist than it is with a fellow neurosurgeon who understands the difficulties of open AVM surgery versus a neuroradiologist who doesn't have to deal with any of the complications in the ICU of the embolization procedure and so on, which is, another very strong argument for this just to be part of neurosurgery completely.
Yep.
Thank you, Phil. We have 2 minutes left. Time flies. I would give the floor to Chris again for final remarks before we close up.
One comment I will make, and this is particularly to Europe and to England and Torstein, as you know, we have drafted an editorial to be published in Neurosurgery. We hope it's in the final stages, but the title is, dual trained neurovascular surgeons. The time has come. And I think you all are very open-minded thinking about this, even if all you've done is surgery. And Marco, you're a great example of someone who's guiding people in the right direction to bring this field to where it should be and will be. And we all don't know where it's going to go over time, but it's a lot of fun doing both. And you feel like you're really doing the right thing for the patients. And I think that's only going to get more prevalent over time.
Thank you, Chris. Great final words. We need to move forward, and we need to embrace this technology and be part of that exciting journey. I thank you, Chris and Phil, for joining us. I thank you for your US support, especially the editorial that you mentioned. I hope we can nudge Europe forward slowly but surely. Thanks to Marco as vascular section chair, and Nikolai being the hands-on chair. Thank you so much.
Thank you. Nice.
Thanks much. Take care.
Thank you.
Thank you.
Bye-bye.
Bye-bye.